Good morning and assalamu. Hello. 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 হ্যাঁ 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 বলো সরি বলো হ্যাঁ আমি শুনতে পাচ্ছি ওকে তাহলে শুরু করি ওকে ঠিক আছে Good morning and assalamu alaikum everyone. Extremely sorry for the delay. I know everyone's very busy, but today technical problem always happens to me. I'm sorry for that. Today I ask about carcinoma of breast. If you're having any problem, please tell me. Carcinoma of the breast, which is one of the commonest malignancies in case of a female worldwide, and now the incidence is also increasing in Bangladesh. Now, the problem is, for the last few days, I've been discussing with the organizers that carcinoma, I'd give a lecture on carcinoma of the breast. Now, I know my audience starts from third year, fourth year, fifth year, and final year. Maybe some other guys are there as well. So it's a large audience of a very different group of students over here. So I was having difficulty about finding a best way to give you a lecture. I needed to find a middle ground, which is not too difficult for the third year and not too easy for the fifth year. So I have made it more clinically oriented. Hopefully it will be very helpful. And I'm sure if you concentrate on this lecture for give me an hour and 1 hour and a half, I'm sure, I think carcinoma of the breast should be a lot easier to you guys. Now, I would start, my approach would be clinically, that is from the history. Okay, so the great Sir William Osler once said that always listen to the patient. They might be telling you the diagnosis. So this, I'm sure, makes you understand how important a good history is. And we all know how important, how clear our conception has to be if you take a good history. And we need the knowledge to take a good history, that is, which is most important. Now, a history starts with a first thing that the history needs is a doctor who looks presentable, who looks important, who looks respectable. Don't look as if you are from a modeling school. Make sure you look like you're from a medical school, and then you ask questions, because breast is a very personal matter for most women, and they want a person whom they can respect to talk about it. Now, the first thing what we need to do is give a consent, take a consent from the patient. Now, it can be individualized. You can make up your own way of taking consent. What I do is I say, good morning and assalamu alaikum. I am Dr. Asif Almas Haque. Today I'm going to ask you a few questions relating to the problem you're having, and then maybe do a few clinical examinations. It may be uncomfortable, but I will not hurt you. But if you feel any discomfort, please tell me. So this is my way of saying the consent. You can make up your own consents. You must always talk about privacy in your consent. The patient must know that there's privacy. We respect her dignity. And if you're female, if you're a male doctor, a female attendant is a must. Even if you're a female doctor, I think a female attendant would be very helpful. Now, first we start with the patient profile. The patient profile, the most important things here are the age. Nowadays, usually we used to get patients above 40 years old. Nowadays, women are more alert, more aware of their health, and many of them are encouraged to do self-breast examinations. As a result, many of the females nowadays come much earlier age, maybe even 30, 35 years of old. At age, we may get patients of breast cancer nowadays. And also the age is also decreasing nowadays because of the unhealthy habits that we are having. We are taking formalin as preservatives, the smokes, the pollution, and our lifestyle, which are mostly detrimental to our health. So which also adds up to our the increase in the malignancy in the younger generation. Sex, of course, male can also have breast cancer, which is much less compared to females. So at this present moment, we will mostly concentrate on female breast cancers. Marital status is important. I am coming to that. Most of the times, the complaint, the patient usually complains that, sir, আমার ডান অথবা বাম বুকে একটা চাকা পাওয়া যাচ্ছে. This is what she says. We get a lump in the left or the right breast. Most of the time, there is no pain. Like all malignancies, pain is always a sign of advanced malignancy. And most of the times, which I have seen patients, they don't have any pain. Even if they have pain, it is usually dull aching pain. Pain is usually a sign of advanced malignancy. In case of breast, it involves the nerves, the muscles, the pectoralis muscle, or even the bones. That's when the pain really happens. And another complaint that commonly is there is the nipple discharge, which is, in case of breast cancer, is blood-stained nipple discharge. History of present illness. The lump, of course, you have to describe about the lump, how long the patient is having the lump. It can be very early. The patient may just be feeling the lump maybe 1 or 2 weeks back, or sometimes, mostly in our government setting, we usually get patients having a lump for maybe 6 months or even 1 year. But there is usually a history of rapid progression, a rapid increase in size. What the patient usually says, now, remember, the patient does not know exactly when the lump has started. What they know is when she has noticed the lump. So there is a difference. Remember, the lump has to increase to such a size when it becomes palpable to the patient. So make sure the lump has been there longer than the patient is saying. So what you should write is that my patient noticed a lump for 2 months back, not the lump is there for 2 months. You should say noticed. Associated pain, usually, as I've already discussed, pain is usually a sign of advanced malignancy. And make sure you always ask about the other breast as well. Pain, one important thing you need to know, definitely pain you have to describe the way we have been used to describing its size, intensity, any radiation, all those things. But most of the time, what I have seen, malignancy, in case of breast malignancy, the pain is usually dull aching, which can be severe in advanced cases when it invades the nerves, the muscles, or the bones. And also, don't forget to ask about the relationship with menstrual cycle. Because if you remember, one of the differential diagnoses of breast cancer would be, fibrocystic disease. Many a times you will feel their lumpiness in breast and you may be confused with a breast malignancy. Now, remember, fibrocystic diseases are usually, the pain is related to it increases during menstruation. Sometimes the patient herself says that during menstruation, the pain is cyclic in nature, and in and around menstruation, the pain increases in intensity. Nipple discharge, usually bloody, that is blood stained. Make sure you ask questions about whether it involves both breast or the single breast. Usually, in case of breast malignancy, the nipple discharge would be from a single breast. You also ask about the symptoms of metastasis. The common sites of metastasis are lungs, bones, liver, and also there are some other places where the metastasis can happen. So in case of lung, you ask about any cough, hemoptysis, chest pain, etc. And overall health, you must ask about appetite, weakness, weight loss, bowel and bladder habit, etc. Now, the history of present illness, usually the way you should write it, for example, I write, you make up your own way of writing it. For example, I write it like this. According to the statement of the patient, she has been relatively well about 2 months back. Then she noticed a lump in her left breast, which was rapidly increasing in size, is not associated with pain, and there is no other complaint. Although if there is other complaints, you can talk about, if there's a nipple discharge, you talk about the nipple discharge. And you talk about the metastasis. If there's signs of metastasis, you talk about that. Also, the overall health, you talk about that in the same paragraph. I mean, you can definitely change the way you talk about it, but you make sure you make a pro forma of how you are going to write the history of present illness, because some of us write very lengthy history of present illness, which bores the person who's listening to it. So make it concise, but make it effective, adequate. That means you have enough information to say whether you are thinking the lump is a malignant lump or a benign lump. That is the most important thing. From the history of present illness, the listener must be able to understand whether you are thinking in the line of malignancy or you are thinking in the line of benign disease. History of past illness is very important. In fact, all the histories, different histories are important in case of breast malignancy. What is important in case of past medical history? Firstly, you need to ask about whether there's been any breast-related diseases previously. For example, let me tell you one example. A patient had something of a lump in her breast for quite a while. We have been doing some investigations, even FNSC, which was inconclusive. But this patient was having a tuberculosis of the breast. So the thing is, the patient previously had a pulmonary tuberculosis. If we had taken that history, it would have been much easier for us to diagnose that. So previous disease history is very important. Previous history of any radiation. For example, the patient has Hodgkin's lymphoma, taking radiation. Radiation is a predisposing factor for malignancy. Medications are particularly important. For example, oral contraceptive pills, hormone replacement therapies. These are all important. Allergy. Now, why did I say allergy is important? Sometimes a patient would come to you with sort of a skin disease of the nipple and areola, and you say that there's some redness or some swelling, sometimes some ulcerations. So you might think this is a skin disease, but this patient may have an associated, excuse me. Hello. Yeah. না এখন চেঞ্জ করার দরকার নেই, আমি আপনার সাথে কথা বলতে একটু পরে কথা বলি, ঠিক আছে? Sorry for that. We have to take the call. It's an extremely important call. Anyway, allergy. Why did I talk about allergy? That it is very important because sometimes the patient may come to you just saying there is some itching, maybe some slight ulcerations or redness in and around the nipple or areola. But there may be an underlying breast malignancy. This is called Paget's disease. We must differentiate between eczema, allergies, and Paget's disease. We have to take a good history about that. Gynecological and obstetric history is very, very important. I'm coming to you why. Family history. Now, you know, the breast malignancy, like all other malignancies, runs in the family, because there may be some genetic predispositions, or it may be just a familial disease even. The breast-related oncogenes, the BRCA1, BRCA2, this runs in the family, especially the first-degree relatives. For example, in case of a female, her mother and the sisters are the first-degree relatives. Even in second-degree relatives, it may be the history is important. But the first-degree relatives is very, very important, especially breast and ovarian malignancies. We'll discuss this later in the future. Socioeconomic history, personal history, smoking history, drinking history. Like all malignancies, smoking and drinking alcohol always predisposes and supports the malignancy. Menstrual history, one of the most important things. Age of menarche, that when menstruation started, and age of menopause. Because what you know is that breast malignancy are sometimes dependent on the estrogen or hormone, or dependent on the hormone, especially estrogen. Now, the length of time the breast has been under the influence of the hormone estrogen is very important. For example, if the patient has early menarche and late menopause, that means the menstrual period, the length of the age he has been under menstruation has been a lengthy period. So the patient it's a predisposing factor for breast cancer. Obstetric history, very important. number of children, age of first pregnancy, and lactation. This is very important because we know the pregnancy is a protective against breast cancer. Number of pregnancy is, the more number of pregnancy, the less chance of breast cancer. Lactation is very important. The earlier the age of lactation, the less chance of breast cancer. Immunization history. As you know that one of your differential diagnoses would be tuberculosis. One of the differential diagnoses of breast malignancy would be tuberculosis. So immunization history can be important in such cases. Now breast examination. Now we will not go into very depth into breast examination because it has to be done. There has to be a video, but time is short today. I've already taken a lot of your time, so I'll go into depth into breast examination. Inspection has to be done in 3 different positions. We all know about this. There are a lot of videos in the YouTube. Just have a look at these videos. What do we look for in inspection? In inspection, we first look at the nipple and the areola. The nipple, the position of the nipple. First, we look at the normal side. Are they at the same level? Is it high up or is it below? The areola, the direction of the nipple. Is there a displacement of the nipple? Very, very important. Then we look at the skin, whether there is any pudgy orange appearance. We'll discuss about pudgy orange in the future. Whether in the skin puckering, whether there's any obvious ulceration, you have to know. Then we look at the axilla, whether there's an obvious axillary swelling that can be seen. Then we look at the arms. Don't forget to look at the arms and the forearms because breast cancer is associated with lymphedema of that respective arm because it usually involves, it may involve the axillary lymph nodes, which blocks the lymphatic drainage of that particular arm. So must inspect the arms as well. As you can see over here, if the left breast is normal in this case, the right breast, you can see an obvious lump over here. The nipple is slightly elevated. It's at a position up. It's as high up position. The direction it is displaced. You can see the lump over here. The skin sometimes may show. For example, let me show you. This is called pudgy orange appearance. That means the orange peel appearance. As you know, this is due to the obstruction of the subdermal cutaneous lymphatics, which causes edema of the skin. This causes the edema of the skin, but there is a pitting where it is attached to the sweat glands of the breast, as you can see over here. This is called the pudgy orange appearance. We can discuss all these things in the future. There are a lot of things to learn in case of breast cancer. So we will discuss this in the future if we get time. This is something like skin dimpling and puckering, as you can see. This is something happens because, you know, in any malignancy, there's a dysmoplastic reaction. Dysmoplastic means it contracts, it pulls all other tissues towards it. There's a bit of fibrosis. So you can see the nipple is directed towards the breast. The malignancy is in the upper and outer quadrant, and the nipple has been contracted or retracted towards that malignancy. And this is called nipple retraction. Now make sure you understand with some female patients have a congenital nipple retraction, or there may be due to some infection, there may be nipple retraction. So it's very important to differentiate between it. It's in malignancy, it would be a recent unilateral circumferential nipple retraction. Then comes palpation. Ideally, the palpation should be done in a 45-degree angle position. Lying position is the better, where you use the palmar surface of your fingers to palpate the lump. There are a lot of videos. Again, go have a look at those videos. Today, I wanted to show you some of the videos, but I'm not having any time because we already lost a lot of time. So I will go directly into the next parts. Now, recording the examination finding. How to do a recording the examination finding. Now, I had a great video. Let me see if I can show you how to record the examination findings. Oh, I'm sorry. This is actually a different computer. My other computer is over there. I was having a problem with the other computer, so it's not coming over here. At a great video how to record the examination finding. I'm sorry for that. I don't have it today. Maybe next time I'll show it to you guys. The way to record it. It's not very difficult. It's quite easy. I'll just show you one in the future. Now you write about the salient feature. The salient feature, you can say that, for example, a salient feature, you can say, according to the statement of the patient, she has been reasonably well about 2 months back. Then she noticed a small lump of the size of a pea on her right breast, which rapidly increased in size. And there is no lump in the other breast, and there is no associated, maybe associated or may not be any association of pain, and there is associated blood-stained nipple discharge. Salient feature, try to write the salient feature in as short as possible, but enough information should be there to show what your provisional diagnosis is. You talk about the malignancy, about the metastasis, whether the patient has any metastasis. You can say that the patient has some cough, but no other signs of metastasis. On examination, what did you find? On examination, there's a lump in the upper and outer quadrant of the right breast, which is not fixed to the overlying skin or the underlying structures. It is non-tender. And there's whether if you can talk about whether there's a nipple retraction or nipple discharge when there's skin involvement, whether in the axillary finding, with the axillary lymph node, did you find out any axillary lymph nodes or not? So talk about those things. I will get to this examination part in a future day, in another day, because today I'd like to cover the whole management process of the malignancy. Then in another day we will discuss about that. But in the meantime, have a look at the many videos that are present in the YouTubes and other places. And I'm sure most of you have, your registrars and examiners and teachers have shown you how to do the clinical examinations of breast and axilla. So have a look at those things. What are the differential diagnoses that may be present in case of if your provisional diagnosis is breast malignancy, definitely in case of Bangladesh, make sure to write about tuberculosis of the breast is another differential diagnosis. Traumatic fat necrosis, ask about any trauma, very important. Traumatic fat necrosis, very much looks like a breast malignancy, so make sure you take the history of any trauma or not. Antibioma, take a history of pain and then long-term antibiotic history. Patient may have chronic breast abscess, which also features something like that. Fibrocystic disease, as I've just talked about that. Fibrocystic disease is the commonest problem with which a female comes to the breast clinic nowadays. Fibrocystic disease, very, very important and very, very common. Also, if the patient is young, make sure that one of the differential diagnoses may be fibroadenoma of the breast. So then there's the investigations after which you confirm your diagnosis. So before I go into investigation, how can you write, what should you write in case of a provisional diagnosis? It can be written in the form of carcinoma of the left breast, then the staging. I'm coming to you how you should stage the diseases. Or you can give a little more information like carcinoma of the left breast in a postmenopausal woman. And then T2, and I'll talk about the Tnm staging just now. Okay. This is the Tnm staging, which is very, very simple. Don't look at the chart right now. It looks complicated, I know, but you have to look at it. The Tnm staging, Tnm actually means tumor, node, and M means metastasis. Tumor means actually the size of the tumor. If it is no palpable tumor, you can write T0, or sometimes in situ tumor as well. But if it is less than 2 centimeter, it's palpable, and less than 2 centimeter, it is T1. If it is 2 to 5 centimeter, it is T2. If it is greater than 5 centimeter, it is T3. And if it can be any size, 2 centimeter, 3 centimeter, but any size involves the skin or the chest wall, is T4. Similarly, node, grade of the node. If no axillary node is palpable, it is N0. If there is axillary lymph node palpable, but if it is mobile, they're N1. And if they're fixed axillary lymph nodes, it's N2. And if supraclavicular lymph nodes are involved, it's N3. And any type of metastasis is M1. No metastasis found, it's M0. First, just learn about this. Then we'll discuss about the other ways, Manchester staging and the other staging. But I personally think the TNM staging is the easiest one. You'll get a lot of pictures of TNM staging all over the globe, all over the internet. Just have a look. Or you can just have a look at this chart. This encompasses both the Manchester staging and the TNM staging in one chart. So it's a very simplified way of showing that thing. Okay, this is another way. Now, before I go into investigation, I just shortly I'll discuss little bit theory about the breast malignancy. Now, what are mainly we get two types of breast malignancy, the invasive and the non-invasive one. The non-invasive comprises of the lobular carcinoma in situ and ductal carcinoma in situ. You all know about what in situ carcinoma means, where it involves only the epithelial layer but does not go beyond the basement membranes. And invasive carcinoma means when it invades the basement membrane. Now forget about all these writings, just remember only one of them, the invasive ductal carcinoma. No special type or NOS, no obvious subgroup. We used to say no special type. So this is the same thing. When they find out something special, some special finding can be found in the in the histopathology, then you can talk about mucinous, tubular, or medullary type of. For example, if it's UD, it sometimes says medullary type of carcinoma. You don't have to learn about it. Just remember the only one thing: there's invasive ductal carcinoma, no special type or no obvious subtype. Commonest site of breast malignancy is the upper and outer quadrant. As you can see over here, I've taken this picture from Bailey and Love. 60% of the malignancy is present in the upper and outer quadrants. Now I come to the investigations. Now remember, investigation is, again, it has to be individualized for each patient according to age, perceived cancer risk, and the characteristics of the lesion. For example, in case of a young patient, you don't want to do mammogram. In case of a young patient less than 35 years old, it's better to go for an ultrasonogram. Again, in case of a patient who have already palpated a large lump, there's no point going for a mammogram. So always the same investigation is not ideal. Now remember this chart. This is a very, very important chart. The triple assessment. I mean, each and every student will be asked one way or the other about this chart in your final prof or any other examination. Whenever any question that's associated with breast comes up, one way or the other, you will be asked a question related to triple assessment. Now, what do we mean by triple assessment? Triple means three. That is, three assessments are done. Whenever we get a lump or any suspicious pathology in breast, we do three things. That is, we clinically assess it. Clinical means we take a history and do an examination of the breast. We do a radiological examination, that's ultrasound and mammogram. We nowadays do other investigations as well, but for basic purposes, ultrasonography and mammogram are the two things that you will talk about. And pathological examination is done by fine needle aspiration cytology and core cut biopsy. This is again the investigations that I'm talking about. It's not very important nowadays. Okay, mammogram. Now, what is important? Just remember, what do we get in case of a mammogram? We usually get a dense opacity, which is usually irregular and ill-defined margins. They will get microcalcification, and most importantly, stellate or speculated appearance. Speculated means katar moto, kata kata appearance thake in case of a breast malignancy, as you can see over here. This is a malignancy. Speculated appearance. This is very important. If you forget everything, just remember this stellate or speculated appearance. This is very important. This is called, this is not important, but just for you guys some information. This is called BIRAS, or Breast Imaging Reporting and Data System. You don't have to know about this. Just know there is a term called BIRAS. That's it. At undergrad level, it is not important. Ultrasonogram. Why is it important? Oh, just a moment. Before I say anything about ultrasonogram, I'd like to talk something about the mammogram. What is mammogram? Mammogram is an X-ray. It's an X-ray of the breast. It's an X-ray of the breast. In the Bailey Lab, it is written very nicely. It's a low voltage, high amperage. And the X-ray radiation is very, very low, less than 1 centigrade. It is less than 1 centigrade. The two views, the craniocaudal and mediolateral views are done. In most of the cases, these are the two views that are done. And it is the investigation of choice for screening. Because, although it is an X-ray, but the chances of malignancy due to mammography is very less, because I have told you that radiation level is very low. That is 1 centigrade. Okay. Now, another investigation that is being done in case is ultrasound. We usually do an ultrasound in case of younger females, that is less than 35 years old. In case of, because their breast is very dense and mammographic appearance are sometimes confusing to understand any malignancy or any other pathology. So ultrasonography is the ideal investigation for younger females, and it's also very helpful as for all other places. It is very helpful in differentiating solid lesions between cystic lesions. Now, once we get a lump, usually once we get a palpable lump, the investigation of choice for us is FNST, fine needle aspiration cytology. We usually use a 23 or 22 gauge needle to extract some fluid from it. Inside that fluid, there are some cells. Now remember, what we are doing here is just collecting some cells, no tissue. So no architectural orientation can be understood. And the false negative levels are quite high. And you always need a skilled cytopathologist. And most importantly, it cannot differentiate between in situ and invasive lesions. Also, with the FNSC, you cannot understand the estrogen and the progesterone receptor levels. So what we do nowadays, most commonly what we do is the core needle biopsy or true cut biopsy. It usually, this needle is quite larger than the other needle. It's around 24, around 14 gauge needle or even larger. It takes a chunk of tissue. So false negative rates are very low. And what it can also differentiate between in situ and invasive lesions. And most importantly, it can confirm ER, that is estrogen receptor, progesterone receptor, and human epidermal growth factor receptor status as well, which is very, very important. That means once we know this, we have the ability to decide whether we would like to go for chemotherapy or go for hormone therapy. That's very important. With any patient who has ER, PR, this receptor is positive, we can use those hormone receptor blockers for these patients. Image-guided biopsies. Now, what are these? Image-guided biopsies are mostly once the lesion is not palpable. Sometimes the lesion is very small, or sometimes the lesion is not palpable. That's when it's very difficult to get enough adequate tissues for biopsy from those lesions. That's why we use ultrasound-guided FNSC or stereotactic. That means we can use mammogram to collect the biopsy. It's not for undergrad level, it's not needed. I think just the term is enough for you guys. That image-guided biopsy. We also say something wire-guided biopsy and all those things. Just learn about that there is something called image-guided biopsies. Now, there's another investigation that's called Sentinel lymph node investigation, Sentinel lymph node biopsy. Now, what's a Sentinel lymph node? Sentinel lymph nodes are the lymph node which has been drained by the lesion. This is the first lymph node that has been drained. That means if we can find out that particular lymph nodes and we can take a biopsy from the lymph node, we can assess histopathology from the lymph node, we can ascertain that whether the lymph nodes are involved or the malignancy has spread to the lymph nodes. And as a result, we can decide whether an axillary treatment is necessary, either in the form of axillary surgery, axillary clearance, or radiotherapy. So this is very important. What we do usually is we use a visual blue dye. We inject the dye in the skin just above the lesion, or sometimes in and around the nipple and areola. We also inject technetium level colloid, which is radioactive in nature. We use this to chemicals. We inject them on the subdermal level. What happens is they travel through the malignancy into the first lymph node, the sentinel lymph node. With a gamma camera or Geiger counter, we can, before giving an incision over the skin, we can identify where the lymph node is. And then we can give a small incision and get to the lymph node. Once we get near the lymph nodes, there are many other lymph nodes. So we can identify that particular lymph node by the visible blue dye which we have injected. We can collect the sentinel lymph node. We can send it for frozen section or any other histopathological investigations, and we can assess whether any axillary clearance is necessary or not. There are some lot of indications, contraindications. Remember that in case of contraindications, just one thing for undergrad level, only one thing that you should know, that is, if there's a palpable lymph node, if there's a palpable axillary lymph node, we do not do sentinel lymph node biopsy. Also, in case of any advanced malignancy, we do not. For example, if the breast, if the malignancy is more than 5 centimeters, in that case, sentinel lymph node biopsy is not necessary, because we think that such a large breast malignancy, that surely it has already involved the regional lymph nodes. Sometimes, in case of very early cancers, in situ malignancies and T1 and T2 type of cancers, sentinel lymph node biopsies may not be necessary. But it's up to the assessment of the surgeon. The surgeon can decide for it anyways. Other investigations. Once you have investigated, that means you have confirmed that the breast malignancy is present, then we can do the staging investigations. What are the staging investigations that we are doing? Number one, the simple staging investigations in our country, what we do is a chest X-ray. In other countries, they usually do a chest CT scan. We do, in case of abdomen, to check for whether there's any hepatic metastasis. We can do an ultrasound of the whole abdomen, especially the hepatobiliary system. As you know, that the bone metastasis is quite common in case of a breast malignancy. What we can do is a bone scan, a technetium level bone scan can be done as well. MRI of breast is also done nowadays, but it is not always available. It's quite expensive. So MRI is an investigation which is done for very special cases. For example, if the patient has an implant, or the patient has been having a previous surgery, in those cases, MRI of breast can be very helpful. For special cases, MRI is not routinely done in case of breast malignancy. Nowadays, MRI guided biopsy can also be done. So that is another thing that you should remember. And the tumor marker is CA15-3. So that's also supportive investigation, whether it is advanced or not. That gives you some investigation ideas. Now, the thing is, what is important is now comes to the most important part. That is the management part. Now, the modalities of the management are local and regional management and systemic management. So what we do in case of local management, we do surgery and radiotherapy. Local and regional means, local means the breast and axilla. And the systemic means the whole body. So for that, we go for chemotherapy and hormonal therapy. Now, this is, of course, dependent on different institutions, whether what would be your ideal way of approaching a particular disease. But there are still simple ideas that we usually follow, and what we do in case of a breast malignancy, if it is advanced, if it's very early, what to do. So I have written a short chart over here, but you don't have to look at it. The simple way to remember this thing is that if it's an early cancer, if the tumor is less than 2 centimeters or even less than 5 centimeters, if the tumor is mobile, that is T1 and T2 type of cancer, usually T1 and T2 type of cancer. And if the lymph nodes are mobile as well, if the axillary palpable lymph nodes which are mobile, that is N1, that is T1, T2, and N1. Or in the another way of saying is stage 1, stage 2. These are called early breast cancers. Again, I'm telling you what we mean by early breast cancers. Early breast cancers means usually the malignancy is less than 5 centimeters. That is T1 and T2. And if the lymph nodes are palpable, it is usually mobile, that is N1. In these cases, what we can do is the local and regional treatments, that is surgical and radiotherapy. We in Bangladesh mostly we go for surgery. Now, in case of undergrad level, I think we can only talk about modified radical mastectomy or Patty's mastectomy. For advanced students, there are other surgeries that we do nowadays as well. That's called breast conserving surgeries. I'll talk about breast conserving surgery in a few moments. But if you look at modified radical mastectomy, what do you mean by that? Modified radical mastectomy, it removes the whole breast, including the areola and the nipple and the malignancy. And then also it clears the axilla. That means it includes the axillary clearance. Together, this is called the modified radical mastectomy. Why is it modified radical? Because previously we used to do the Halsted radical mastectomy, which also involved the pectoralis major muscle. Now, nowadays we have seen that the muscle, resection of the muscle does not help with the survival of the patient. So we nowadays do the modified radical mastectomy. So in case of stage 1, stage 2 tumors, I think the ideal answer for you guys would be do the modified radical mastectomy. If the examiner asks that, is there anything else that we can do? That answer would be yes, sir, we can do. If the tumors are less than 4 centimeters, then we can go for breast conservation surgery. There are a lot of things about breast conservation surgery. We will talk, maybe if we get a future class, if we get a class in the future, we'll discuss about that. But for the time being, just talk about modified radical mastectomy and breast conserving surgery. So in case of early breast cancer, we go for modified radical mastectomy. In case of advanced breast cancer, what do you mean by advanced breast cancer? In case of advanced breast cancer, the tumor is usually more than 5 centimeters, or tumor may have any size, but it's involving the breast skin or the chest wall or the muscle, pectoralis major muscle. So any of these involvement, any size of breast, but it involves the skin or the muscle or the chest wall. That means it's locally advanced breast cancer. Or in case of lymph nodes, it must be palpable but fixed lymph nodes. That constitute the stage 3. Now, in this case, what we have to do is just local and regional therapy will not be enough. In this patient, the systemic therapy is most important, because we should all remember the breast is a systemic disease. That means once you've diagnosed a breast malignancy, it has already spread. It has already spread towards the body. So a systemic approach of in the management of breast malignancy is very, very important. So in this case, the management becomes a little tricky. Whether you're going to go for new adjuvant chemotherapy or adjuvant chemotherapy, this is very, very important. Ideally, if the breast malignancy is fixed to the skin, if there's any fixity, then it is better to go for new adjuvant chemotherapy, which usually downstages the malignancy, which decreases the size of the malignancy, and sometimes, most of the time, it becomes mobile. And then a surgical resection becomes easier. Sometimes we also do an adjuvant or new adjuvant radiotherapy as well. A radiotherapy is given to the chest wall or even to the axilla if there's fixed lymph nodes, and then a surgery is being done. So if in case of locally advanced breast malignancy, you must talk about the systemic disease. There will always be a discussion whether the systemic therapy, chemotherapy, radiotherapy, and also the hormone therapy, whether they will be given before or after. If the malignancy, if you think it's inoperable, when the malignancy becomes inoperable? It becomes inoperable when the malignancy is fixed to the skin or the chest wall. So in these cases, we must go for a new adjuvant systemic therapy, which may be new adjuvant chemotherapy or new adjuvant hormonal therapy, which downstages the tumor. After that, once it becomes downstage, then we go for surgery. Lastly, it comes advanced breast cancers. These are usual. This means stage 4, or there is usually a metastasis. Metastasis may be in the chest, maybe in the bones, maybe rarely even in the liver. So in these cases, the ideal thing to do is go for systemic therapy. That is chemotherapy and hormonal therapy. And if there is a very big mass, it causes extremely a lot of pain. It may be ulcerated. There may be foul smelling discharge, which is hampering hampering the life of the patients. Then you can go for a toilet mastectomy. But remember, toilet mastectomy is always a palliative surgery. It's never a curative surgery. This is again, I've written those things in short. I don't think this is very important. New adjuvant chemotherapy, treatment of inoperable chemotherapy. Always remember that if it is advanced, it's always preferable to go for systemic therapy. If it is not advanced, if it's in the earlier stages, we go for surgery. This is the easiest, simplest way to say is, sir, if it is not advanced, advanced means stage 3, stage 4. Stage 1 and 2, we go for surgery. Stage 3, we go for chemotherapy or hormonal therapy, and then, if possible, then surgery. And stage 4, if it's a metastatic disease, mostly we will go for systemic therapy. That's it. We talk a bit about the prognostic factor. Just one thing I want you to remember, that the most important prognostic factor is the axillary lymph node status. Very, very important. Then tumor size, estrogen receptor and progesterone receptor status. These are also very important. Histological grade is very, very important. This is one thing that I want to show. It's not important for undergrad level. You don't have to know about it. That Nottingham Prognostic Index. It's not, you don't have to know about it. What is more important for you guys to learn is that what are the important factors that is taken into account. You can see Nottingham Prognostic Index is 0.2 into S plus N plus Z. So S is the size of the tumor, N is the nodal status, and G is the grade of the tumor. What is important here, what you have to understand is these are the three things that is most important. Size of the tumor, nodal status, and the grade of the tumor. Grade of the tumor means whether it is a poorly differentiated tumor, whether it's well differentiated or moderately differentiated tumor. If it's a poorly differentiated tumor, the number is 3. If it's a well differentiated tumor, number is 1. Adjuvant chemotherapy, we use a lot of things, cyclophosphamide, methotrexate. Nowadays we use anthracyclines like doxorubicins, epirubicins. Taxanes are also used like paclitaxel, docetaxel. Not important. Just know that chemotherapy is necessary. At undergrad level, no one's going to ask you about what are the names of the different chemotherapeutic agents that we are going to use. Hormonal therapy, just know the name of the hormones that we use. For example, if the patient is estrogen receptor positive, then we use selective estrogen receptor modulators. It's called tamoxifen. And this is used in pre-menopausal women. And in case of postmenopausal women, if they're estrogen receptor positive, we use aromatase inhibitor. That's anastrozole, letrozole. What are these two things doing is aromatase inhibitor. These enzymes are found in the peripheral, the fatty tissues. What they do is they convert the steroids into the hormones, into the estrogen hormones. So when you inhibit the aromatase enzymes, those hormones, the estrogens, are no longer produced. So they also decrease the rate of increase in size of the tumors. Yes, there are a lot of questions that's coming. Yeah. And another hormone therapy, or it's not exactly a hormone, it's a monoclonal antibody that's being used, that is HER receptors. HER means human epidermal growth factor receptor blockers. That's called trastuzumab, or the chemical, the company name is Herceptin. It's commonest thing that's being used nowadays. So if the HER2 receptors are positive, then we use this monoclonal antibody receptor blocker that's called trastuzumab or Herceptin. Remember, HER does not mean Herceptin. HER means human epidermal growth factor receptor blocker. Of course, we go for radiotherapy. As I've already discussed, radiotherapy is usually given in the neoadjuvant setting. when the tumors are usually fixed. If the tumor is fixed, if the lymph nodes are fixed, then we give radiotherapy. Now, if we have done axillary clearance, we do not go for radiotherapy, but because then there will be high chance of lymphedema of the arms. So what we do not do that. Nowadays, radiotherapy is given in case of locally advanced tumors where the tumors are fixed or the lymph nodes are fixed to the walls. So locally advanced breast cancers are given radiotherapy. Follow-up, again, follow-up is individualized. Different hospitals have different ways of follow-up. Some hospital, what they do is first 1 year they go for 3 monthly or 4 monthly checkups. Some of the hospitals also go for a 6 monthly checkup. But ideally, what you can say is that for the first 2 years, we usually go for 3 monthly checkup. Then next 2 years, we go for 6 monthly checkups, and then and on yearly checkup. What we do is we take again a history, a clinical examination of the breast. We may also do some blood work like CA15-3. We can also go for that. If we find anything suspicious, we may take the biopsy. A mammogram, usually of the contralateral breast, is very important. You must remember that once you have a malignancy in one breast, there's always a chance that there may be a malignancy in the other breast. So that thing has to be kept in mind. If there is any chance of metastasis, then we also have to do a CT scan of the abdomen or ultrasonogram, all these investigations. Bone scans are usually done, but these are done only when you think there is a chance of metastasis. Ideally, we go for just like a short history and clinical examinations, and maybe a mammogram, and yearly mammogram. That's good enough for that. So follow-up can be individualized. In most of the hospitals, the follow-up routine is usually first 2 years. First year is 3 monthly. Second year and third year it's 6 monthly, and next 2 years it is yearly, and after that maybe 5 yearly checkup. That's it. So you can just individually, you can check out with your own hospital system, and you can write your own way. There is no specific rigid format for this follow-up. It's always individualized. Thank you, and stay safe. I'm sorry for today's mishap. I don't know what happened with my computer. The other computer was not at all working, so there was some problems that what I was having. Thank you for staying. Thank you for your patience, and thank you for staying with me for so long. A lot of people has been there, a lot of questions. I think I've already taken a lot of your time. So today, and there's prayer today. So thank you very much for your patience and staying with me, and stay safe. Thank you very much.